Foundations of Maternal, Newborn, and Women's Health Nursing by Murray, McKinney, Holub, and Jones, 7th edition. Chapter 25, Family Planning. Family planning involves choosing if and when to become pregnant. It includes contraception, the prevention of pregnancy, as well as methods to achieve pregnancy, thinking about goals for having or not having children, and how to achieve those goals is called a reproductive life plan. There are various reproductive life plans, and each is unique to a woman's own personal goals and dreams. Chapter 26 describes methods used by couples having difficulty attaining pregnancy. This chapter focuses on techniques used to avoid pregnancy. If both partners are fertile, approximately 85% will become pregnant over the course of a year without using contraception. Therefore, those who wish to avoid or control the timing of pregnancies should practice effective contraception. Approximately 61 million women in the United States are fertile, sexually active, and do not currently desire pregnancy. Of those women, 62% are practicing contraception. However, they may not be using contraception consistently. Unintended pregnancies are those that are unwanted or are mistimed, occurring in women who may wish to become pregnant at a time in the future, but not at the time their pregnancies occur. The ability to delay and space childbearing is crucial to women's social and economic advancement. Women's ability to obtain and effectively use contraceptives has a positive impact on their education and workforce participation, as well as on subsequent outcomes related to income, family stability, mental health and happiness, and children's well-being. In the United States in 2011, 45% of pregnancies were unintended. Although this is an improvement from the previous 51%, it is still much higher than most industrialized nations. A Healthy People 2020 goal is to increase the number of intended pregnancies to 56%. Because most contraceptive methods available are the responsibility of women, they often choose the type of contraception used. During a woman's reproductive lifetime, her needs for contraception evolve. Most women use a variety of methods before they reach menopause. Because the average woman in the United States bears only 2 children, she must make contraceptive decisions for more than 30 years. Many of those years occur after she has completed childbearing and is highly motivated to avoid further pregnancy. Information about contraception. Common sources. Women often obtain information about contraception from friends, relatives, the internet, television, and magazines. They seek answers to practical questions about side effects, effectiveness, comfort, and partners' responses. The information they receive, however, is often incomplete or incorrect when their source is not a qualified healthcare professional. Women frequently turn to nurses in outpatient ambulatory office settings, birth settings, and even social settings for accurate information about family planning. Role of the nurse. The nurse's role in family planning is that of counselor and educator. To fulfill this role, nurses need current, correct information about contraceptive methods and should share this information with women who seek their advice. Unintended pregnancies may occur less often if women had adequate ongoing education and reevaluation regarding their chosen method. The initial teaching that accompanies selection of the contraceptive technique may be insufficient to meet the woman's needs. Reinforcing teaching and providing an opportunity to ask questions after initial use can help ensure that the woman is using the method correctly and is satisfied with the method. A woman is more likely to use contraception if she has received counseling that is directed to her own needs, instead of general information about contraception. Therefore, the nurse should provide individualized family planning information to women in every situation in which it would be appropriate. Nurses should feel comfortable discussing contraception and be sensitive to the woman's concerns, feelings, and culture. When discussing family planning, the woman's preferences take priority. Care should be taken that nurses do not introduce their own biases toward or against specific methods. The focus of counseling should be tailored to the reproductive life plan goals of the woman and her partner. Counseling about contraception should include the following: Types of contraception available, both reversible and permanent. Risks and benefits of each and determination of which methods may not be safe based on health status or concurrent medication use. How to ensure proper use of each method to maximize effectiveness. What to do if an error is made. Emergency contraception, specifically access and instruction. Backup methods and when they should be used. What to do if the woman wants to change methods. Questions and concerns. Considerations when choosing a contraceptive method. The perfect contraceptive method does not exist. Each has advantages and disadvantages. Women change contraceptive methods as circumstances in their lives change and in response to dissatisfaction with side effects or other traits of their current contraceptive. Women often try several methods before finding one that is satisfactory. Some women have an interval of using no contraception before beginning a new method, even though they do not wish to become pregnant. Of women who practice contraception, 67% currently use reversible methods, primarily oral contraceptives, the patch, the injectable and vaginal ring, long-acting reversible contraceptives, such as an intrauterine device or the implant, and condoms. The most popular methods of contraception in the United States since 1982 are OCs and female sterilization. However, the most popular methods are often not right for every woman. Nurses can help women weigh the factors involved in choosing a family planning method. Careful consideration of all factors can help a woman choose the safest method that best meets her current needs. Safety. The safety of a contraceptive method is a primary consideration and is unique to each woman's health status. Medical conditions or social practices, such as tobacco use, may make certain methods unsafe. For example, OCs should not be used by women who have had a thromboembolic event, such as deep vein thrombosis or stroke, because the hormones in the contraceptives increase the risk for recurrence and mortality. It is imperative for nurses who provide contraceptive counseling to be well versed in the Center for Disease Control and Prevention's U.S. medical eligibility criteria for contraceptive use and U.S. selected practice recommendations for contraceptive use, most recently published in July 2016. However, it is important to understand that the use of contraceptives, even hormonal contraception, is generally safer than pregnancy. No contraceptive, other than abstinence practiced perfectly, is 100% effective in preventing sexually transmitted infections. The risk for exposure to STDs should be discussed when counseling women about contraceptive choices. The male condom is inexpensive and offers the best protection available. It should be used whenever there is a risk for STD exposure, when a woman engages in high-risk sexual behaviors, or if one partner may have an STD, and even when another form of contraception is practiced or during pregnancy. Effectiveness. The importance of avoiding pregnancy must be considered when choosing a contraceptive method. The woman may wish to delay pregnancy for a time, but may not mind if pregnancy occurs earlier. Other women may be extremely upset about an accidental pregnancy. Efficacy is determined by how well the method prevents pregnancy. Effectiveness rates reflect the following two types of contraceptive failure. 1. The ideal, perfect, or theoretic effectiveness rate refers to perfect, consistent use of the method with every act of intercourse. Failures are caused by a problem with the method itself rather than with the use of the method. 2. The typical, actual, or user effectiveness rate is most useful because it refers to the occurrence of pregnancy under typical use of the method. Failure is presumably the result of incorrect or inconsistent use of the technique. The difference between the two rates of effectiveness shows how forgiving a method is, that is, how likely pregnancy is to occur if the use is occasionally imperfect. For example, in 100 women using OCs in 1 year, perfect use results in 0.3 pregnancies, but typical use results in 9 pregnancies. The typical failure rate is more meaningful when counseling women and their partners. When comparing different methods, the same method of analysis should be used. Efficacy is highly correlated to accuracy of use. It drops greatly when the user does not understand how to use the method. The failure rate commonly decreases after the first year of use, as experience with the method leads to more accurate use. Combining two less reliable methods, for example, a condom and a spermicide, increases effectiveness. LARCs, IUDs, and the contraceptive implant are the most effective reversible methods and do not require intervention by a woman or her partner to achieve this efficacy. Other factors that affect the number of unintended pregnancies that occur with contraceptive use include frequency of intercourse and age of the woman. Women who have more frequent intercourse have more opportunities for failure. As women progress into perimenopause, fertility rates decline. Acceptability. The effectiveness of a method should be balanced against its acceptability to the couple. For example, a permanent sterilization is an extremely effective method but is unacceptable to couples planning to have children at a later time. Side effects or religious cultural objections may cause some women to choose less effective methods. A woman or her partner may be concerned about certain contraceptives because of perceived or suspected side effects such as weight gain. A chemical contraceptive such as a spermicide or the sponge may appear messy and unacceptable because it is unattractive or may cause vaginal irritation. Women of any age who are not comfortable touching their bodies may be unlikely to accept methods that involve inserting a device into the vagina or assessing the cervical mucus. Convenience. Convenience is another important factor in choosing a contraceptive method. If the woman perceives her contraceptives as difficult to obtain or use, time-consuming, or too much bother, she is less likely to use it consistently, even if her level of motivation is very high. The education she receives about the method may affect her perception of its convenience. Women who are knowledgeable about their family planning method are less likely to think the contraceptive is difficult to use. Methods that can be used monthly or weekly instead of daily, or with each act of intercourse, are more convenient and likely to lead to better compliance. Other inconveniences include breakthrough bleeding, spotting between periods, common with some methods, or needing to visit the healthcare provider's office for a prescription or injection may be viewed as very inconvenient. The desire to avoid monthly menstruation also should be considered. Some women prefer extended cycles with several months between menses or to avoid menstrual periods altogether. Extended or continuous use of OCs, the patch, and the ring may be used. Hormone implants or injections and IUDs may also lead to amenorrhea, absence of menstruation, in some women. Education needed. Women may fail to use contraception because they do not understand the risk of pregnancy. They may not be familiar with the variety of methods available or the risks and benefits of the different types. Some methods, such as condoms, involve very little education, whereas others are more complicated. Women using natural family planning methods need extensive education about body changes that indicate ovulation to practice these methods successfully. Benefits. Some methods have special benefits that should be discussed. For example, OCs have many non-contraceptive benefits, such as reduction in acne, decreased bleeding during periods, and decreased menstrual cramps. Natural family planning methods and the copper IUD offer freedom from exposure to hormones. Condoms provide better protection against HIV compared with other contraceptives. Side effects. Some methods of contraception have bothersome side effects that should be explained clearly in advance and when educating women about the advantages and disadvantages of each method. When women know what to expect, they often are more willing to tolerate the side effects and continue using the method, especially if they know that they do not pose a health risk. Effect on spontaneity. Contraceptive methods related to coitus, sexual intercourse, such as chemical or mechanical barrier methods, withdrawal, and periodic abstinence, must be used just before sexual intercourse. They require skill and motivation near the time of intercourse and may be more likely to be used inconsistently or incorrectly. The fact that these methods must be readily available and interrupt lovemaking increases the chance that they may not be used. Some couples remedy this problem by including application of the contraceptive device, such as a condom, as part of foreplay. Others prefer methods such as OCs or LARCs that do not interrupt sexual activity. Availability. Condoms and spermicides are readily available without prescriptions. They can be purchased anonymously at any time without a visit to a healthcare provider. This may be important to an adolescent who wants to hide her sexual activity or to women who are embarrassed to discuss contraception with a healthcare provider. Expense. The cost of family planning methods is important. Less effective contraceptives are often chosen by some couples to save money. These methods may be less expensive but more likely to result in pregnancy, which costs more than the yearly expense of any contraceptive method. The per-use cost of methods can be compared with long-term expense. The price of condoms or spermicides is relatively low, but frequent use makes them expensive over a period of years. Couples may find them economical for occasional sexual intercourse or until they can afford a more expensive method. Methods that depend on periodic visits to a healthcare provider are more costly than over-the-counter methods. However, the visits provide an opportunity for teaching that may enhance contraceptive effectiveness. Such visits also provide an opportunity for health screening and discussion of other health concerns. LARC methods are very cost effective over a 3 to 10 year period because their failure rate is so low. Publicly funded family planning clinics may provide free or low-cost contraceptives as well as counseling about all contraceptive methods and follow-up services. However, women who attend these clinics may have a long wait and may see a different healthcare provider at each visit. Family planning is covered by many state Medicaid programs and most insurance companies. As of September 2017, the Patient Protection and Affordable Care Act designates a list of preventative services that must be covered without out-of-pocket costs to the consumer. Those services include provision of all FDA-approved contraceptive methods, along with sterilization procedures and contraceptive counseling to all women. Preference. The woman usually makes the final decision about her contraceptive method, and her satisfaction with her choice is crucial. Consistent use of any method depends on whether it meets the needs of the woman and her partner. If the woman feels pressured to choose a certain method, or if the chosen method fails to live up to her expectations, use is more likely to be inconsistent. The opinion of the woman's partner and her friends also may influence her choice of method. Religious and personal beliefs. Religious or other personal beliefs affect the choice of contraceptives. Certain religions may not believe in the use of any contraceptives other than natural family planning. Culture. Culture may influence the method chosen. Some cultures place a high value on large families, and especially on male children. A woman may have more pregnancies than she might otherwise desire in an effort to have sons. Asian and Hispanic women are often very modest and do not talk about sexuality with others. They need to feel very comfortable with the nurse before talking about sexual matters. Taking time to establish rapport before discussing intimate subjects is important. Some cultures and religions restrict a woman's activities during menses. Methods that cause increased bleeding or breakthrough bleeding as a side effect may not be acceptable to these couples. If there is a cultural taboo against a woman touching the genital area, sponges, diaphragms, spermicides, female condom, or the contraceptive ring would not be acceptable. Other considerations. Women also consider factors other than those discussed previously when choosing a contraceptive. The length of time before a pregnancy is desired will determine whether a long-acting contraceptive is appropriate. The breastfeeding woman must choose a method that will not harm the baby or reduce milk production. The woman at risk for acquiring or transmitting an STD should use condoms either alone or with another more effective method of preventing pregnancy. Women in a situation of intimate partner violence often have inconsistent use or problems with their contraceptive method. These women are often at risk for unintended pregnancy because of their partner's interference with their use of contraceptives. Informed consent. Some methods have potentially dangerous side effects. Every woman should receive information about the chosen contraceptive method and its proper use, its risks and benefits, and alternative methods available. The nurse should thoroughly document that the woman received and understands this information. Some methods, such as permanent sterilization and LARC methods, require written consent. Adolescence and contraception. In 2013, 47% of high school students reported that they had experienced sexual intercourse, 34% that they were currently sexually active in the last 3 months, and 41% said that they did not use a condom the last time they had sex. Although the rate of adolescent pregnancies has decreased in recent years, adolescent pregnancy is still a major problem. Because of the serious impact of pregnancy on adolescents, the U.S. Healthy People 2020 goals include the following: increasing condom use at first intercourse to 73.6% of adolescent females and 88.6% of males. Increasing the number of sexually active adolescents ages 15 to 17 years who use a condom and hormonal or intrauterine conception at first and most recent intercourse. Adolescent knowledge. Many adolescents have little knowledge about their own anatomy and physiology, including how and when conception occurs. They are likely to learn about contraception from other teenagers who often pass on incorrect information. Adolescents have higher failure rates with all methods of contraception. Contraceptive failure is almost twice as likely in teenagers as in women aged 30 years or more. Misinformation. Misinformation and erroneous beliefs about contraception are common among teens. Some teenagers assume they cannot become pregnant the first time they have intercourse. Others believe they must have an orgasm or must have been menstruating a certain length of time to become pregnant. Even adolescent mothers are more likely to be inconsistent in contraceptive use or to use ineffective methods. Although many adolescents have anovulatory menstrual cycles shortly after menarche, they cannot depend on absence of ovulation to avoid pregnancy because some will ovulate before their first menses, and a pregnancy can result from any intercourse near ovulation. Teenagers may douche, insert a solution into the vagina after intercourse to wash away the sperm and prevent pregnancy. However, douching is ineffective because sperm may enter the cervix very soon after ejaculation. Coitus interruptus, withdrawal, is used by some teenagers, but it is unreliable. It requires more control over timing of ejaculation than most adolescent boys have, and it is important to educate adolescents that there is a small amount of sperm present in the pre-ejaculate fluid. Risk-taking behavior. Adolescents often have a feeling of invincibility. They are more likely than adults to take risks in sexual activity because they believe their chances of becoming pregnant are low. They often do not plan intercourse and therefore are not prepared with contraceptives. This behavior may lead to STDs and pregnancy. Most teenagers wait at least 6 months after becoming sexually active to begin using contraception. Some adolescents have ambivalent feelings about becoming pregnant. Although they do not plan to become pregnant, they do not have a firm commitment to avoid pregnancy during their teenage years. Discussing how pregnancy may affect them and their life goals may help determine their true feelings about becoming pregnant. Counseling adolescents. Nurses who counsel adolescents about sexuality should be sensitive to their feelings, concerns, needs, and different communication styles. They should put aside their own personal feelings about adolescent sexuality. For an adolescent to seek information about contraception, she must admit that she is and plans to continue to be sexually active. She may be afraid to ask about contraception because she does not want anyone to know she is sexually active. such as with the use of a parent's health insurance, or she feels she will be lectured or judged about her behavior. Her need for secrecy may cause her to miss appointments for family planning. The nurse should be adept at determining the adolescent's needs and reassure her that her visits are confidential and what is discussed will not be shared with others. Each contact with the healthcare system provides an opportunity for counseling that should not be missed. Visits to a healthcare provider for well woman checkups, minor illnesses, or pregnancy testing provide such opportunities. If an adolescent thinks she might be pregnant, but the pregnancy test result is negative, she can be asked about her desire to become pregnant. She may be particularly interested in pregnancy prevention at that time. The nurse can assess the adolescent's use of contraception and the adequacy of her knowledge and can provide information and resources as appropriate. Although nurses should encourage adolescents to discuss contraception with their parents, many teenagers will forego contraception rather than talk to their parents about it. Therefore, they need other reliable sources of information. Schools have helped increase birth control use among adolescents by offering information about family planning and prevention of STDs. Contraceptive services also are available on some school campuses. School nurses in classroom discussions supply information about abstinence as well as contraception. Encouragement to delay becoming sexually active and discussion of the effect pregnancy might have and ways to remain abstinent are included. Some family planning clinics are open after school, during evenings, and on weekends and have staff who are especially skilled in working with adolescents. The pelvic examination, a source of great anxiety for many young women, is not necessary for a prescription for most forms of contraception in healthy women and may be postponed. Current recommendations from the National Cancer Institute state that cervical cancer screening Pap tests should occur every 3 years from ages 21 to 29 years, regardless of the age of sexual debut. Adolescents and young women who forego speculum or pelvic examinations may be tested for chlamydia and gonorrhea from a urine sample, without an invasive examination. During the first counseling visit, the adolescent should receive information about all appropriate contraceptive methods. Taking this time to explain different methods helps dispel misinformation and allays the common concerns of adolescents about potential adverse health effects of contraceptives. It also helps a teenager feel comfortable in the clinic setting and with the nurse. Because of her youth and possible lack of knowledge about anatomy and physiology, the adolescent often needs more extensive teaching than does the older woman. Liberal use of audiovisual materials such as pictures, anatomic models, and samples of various methods helps the young adult understand the information more easily. For example, giving her a patch, a vaginal ring, and a condom to manipulate or showing her the packet of pills she will be using are important aids. Using understandable terminology is especially important when teaching adolescents. The nurse should know street terms for body parts and sexual intercourse because they may be the only words that are familiar to the teenager. Adolescents are most successful when they choose contraceptive methods that are easy to use and seem unrelated to coitus. The most popular contraceptives for adolescents are OCs and condoms. Teenagers often choose OCs because they are safe, have few contraindications, seem unrelated to sex, and are not difficult or messy. In addition, they increase bone density, regulate menses, reduce menstrual flow and cramping, and may decrease acne. Adolescent girls may, however, be quite inconsistent with daily pill ingestion. Methods such as a ring used once a month or a patch used once a week may be more useful. Use of LARCs is particularly effective in adolescents and is recommended by the ACOG as first-line contraception for adolescents. Teens are more likely than older women to discontinue any method for side effects such as spotting. Their concerns should be taken seriously, and attempts should be made to alleviate side effects. Otherwise, they are likely to stop using the method, often without notifying their healthcare provider, with a pregnancy a possible result. They should understand all aspects of management of their contraceptive method and when a backup method is necessary. Adolescents may use condoms alone to prevent pregnancy and STDs, especially at the beginning of a relationship or with casual partners. With long-term partners, they may discontinue condom use and use only hormonal methods. Some may use condoms, with or without hormonal methods, only if they have casual partners or if they are very concerned about both pregnancy and STDs. Condom use should be encouraged to prevent STDs, even when another contraceptive method is used. Discussing perceived barriers to using condoms helps dispel misconceptions about pregnancy and STDs. Many young women are uneasy about asking their partners to use condoms. Discussing how to negotiate condom use with a partner can be particularly helpful. Teaching should include signs of STDs and what to do if they should occur, in addition to the current CDC recommendation of annual screening for chlamydia and gonorrhea for all sexually active women ages 25 and under. Using condoms and an OC or LARC method provides highly effective contraception along with protection from STDs and should be encouraged. Contraception use in perimenopausal women. Pregnancy is uncommon after the age of 50 years. However, perimenopausal women may continue to ovulate as long as they have regular menstrual periods, and some ovulate even when indications of menopause are present. Therefore, contraceptive counseling regarding the continued use of contraception until a woman is 12 months past her last period is important for these women. Fertility begins to decline when women reach 35 to 40 years, but they are still at risk for unintended pregnancy. In fact, more than 30% of pregnancies in women over the age of 35 years are unintended. Therefore, the nurse should offer these women contraceptive counseling whenever possible. Permanent sterilization is a very common method used by women who are older than 30 years. Healthy, non-smoking women in their 40s can use combined hormonal contraceptives, COCs, ring, patch, to provide contraception and help regulate the irregular bleed that often accompanies perimenopause. Women who smoke and are over the age of 35 years should not use estrogen-containing contraceptives. Barrier methods, progestin-only contraception such as the contraceptive injection, progestin-only OCs or LARC methods are safe choices for the perimenopausal woman who may smoke or have other health concerns that make other methods unsafe. Perimenopausal women should have regular physical examinations to identify any conditions that would necessitate a change of contraceptive method. Methods of contraception. Sterilization. Sterilization, both male and female, provides non-reversible permanent contraception. Couples considering sterilization need counseling to ensure they understand all aspects of the procedure and its permanence. When the procedure is planned immediately after childbirth, the decision should be made well before labor begins and ideally during a third trimester of pregnancy. Future marriage, divorce, or death of a child may cause couples to regret their decision. The greatest risk for later regret occurs of women younger than 30 years of age at the time of sterilization, when there is pressure from a spouse, when there is a medical indication, or when the couple did not receive enough information. Complications of sterilization are similar to those of any surgery, such as hemorrhage, infection, and anesthesia complications. Although pregnancy is rare after sterilization, the risk for failure should be discussed. Pregnancies occurring after tubal sterilization are more likely to be ectopic. Tubal sterilization. Tubal sterilization is widely used throughout the world. The procedure involves cutting or occluding the fallopian tubes to prevent fertilization and can be performed at any time. Many couples choose surgical tubal sterilization, tubal ligation, at the time of a cesarean birth or before hospital discharge after vaginal birth. The first 48 hours after vaginal birth is an optimal time for the surgery because the fundus is located near the umbilicus and the fallopian tubes are directly below the abdominal wall. When performed after childbirth, regional, spinal, or epidural anesthesia is most commonly used. Interval sterilization, not associated with childbirth, is generally performed as outpatient surgery under general anesthesia. Interval sterilization, tubal ligation, is usually performed in one of three ways. A mini laparotomy incision may be made near the umbilicus in the postpartum period or just above the symphysis pubis at other times. Surgery also can be performed through a laparoscope inserted via a small incision. The third method is performed during other surgery, generally with cesarean birth. With each method, the surgeon blocks the tubes with clips, bands, or rings, removes a piece of the tubes and ties the ends, or uses electrocoagulation to destroy a portion of the tubes. If portions of the tubes are removed, they are sent for pathologic examination to ensure the tissues are actually fallopian tubes. Surgical tubal ligation is approximately 99 to 99.5% effective. After sterilization, the woman avoids intercourse, strenuous exercise, or lifting heavy objects for 1 week. Mild analgesics may be needed for pain. The woman should call her healthcare provider if she has a fever over 38 Celsius, 100.4 Fahrenheit, fainting, severe pain, or bleeding or discharge from the incision sites. Non-surgical sterilization is also possible. Essure involves the insertion of a small nickel coil through the cervix, vagina, and uterus, and then into each fallopian tube. This procedure can be performed in a physician's office with local anesthesia or as an outpatient surgery. The tubes become permanently blocked during the next 3 months as tissue grows in and around the inserts. During this time, another contraceptive method is necessary. A hysterosalpingogram to confirm bilateral tubal occlusion is performed at the end of 3 months. The ACOG emphasizes the importance of the hysterosalpingogram at 3 months to ensure the tubes are completely blocked. Essure is over 99% effective but should be avoided for those women who have a nickel allergy. There is continued surveillance of the safety of Essure. Vasectomy. Vasectomy, male sterilization, involves making a small incision or puncture in the scrotum to cut, tie, cauterize, or remove a section of the vas deferens, which carries sperm from the testes to the penis. After vasectomy, sperm no longer pass into the semen. Although performed less frequently than female sterilization, vasectomy is a very popular method of contraception. It involves a lower morbidity rate and has a lower failure rate compared with tubal sterilization. Because it can be performed in a physician's office using a local anesthetic, it may be less expensive as well. Vasectomy is approximately 99.9% effective. After surgery, the man rests and then wears a scrotal support for 48 hours. He applies ice to the area for 4 hours and takes a mild analgesic, if needed. He should avoid bathing for 24 hours. Strenuous activity should be avoided for 1 week. The healthcare provider should be notified of fever, severe pain, bleeding, or discharge at the site, swelling greater than twice the normal size, or a painful nodule. Intercourse may be resumed in 1 week if the man is not sterile at that time. Sperm may be present in the ductal system, distal to the ligation of the vas deferens, and the man may be able to impregnate a woman until sperm are no longer present in the semen. The couple should understand that complete sterilization may not occur for 3 months or more. The man should submit a semen specimen for analysis at 8 to 16 weeks to be sure that sperm are no longer present. Long-acting reversible contraceptives. Intrauterine devices, IUDs, are long-acting contraceptives that are inserted into the uterus to provide continuous pregnancy prevention. The copper T380A Paragard and the levonorgestrel intrauterine system, LNG-IUS, or Mirena, Skyla, and Liletta, are all shaped like the letter T. Paragard is effective for 10 years, Mirena is effective for 5 years, and Skyla and Liletta are effective for 3 years. IUDs are more effective than any other contraceptive method except Nexplanon and male sterilization. IUDs can be inserted at any time the woman is not pregnant and does not currently have an STD or pelvic infection. Insertion immediately after delivery of the placenta and during lactation are safe. Paragard is effective immediately, and no backup is required. If Mirena, Skyla, or Liletta is inserted within 5 days of the start of the last menses, no backup contraceptive is needed. If it is inserted later, a backup contraceptive should be used for 7 days. Fertility returns promptly when the device is removed. ACOG recommends increased usage of IUDs in women of all ages and regardless of previous pregnancy history because they are a long-term, cost-effective means of lowering the risk for unintended pregnancy. A large proportion of women have free or low-cost access to IUDs because of the Affordable Care Act. Many women have misconceptions regarding the safety and effectiveness of IUDs. Although safety was a concern with very different early models in the 1970s, IUDs are considered very safe at this time. IUDs are convenient, long-term, continuous contraceptive methods and eliminate the need to take pills, have injections, or perform other tasks on a daily basis or just before intercourse. IUDs can be used by some women who cannot use other estrogen-containing hormonal contraception. They are considered safe for adolescents, nulliparas, and if they use condoms for women at risk for STDs. Action. All IUDs create a sterile inflammatory response in the uterus that results in a spermicidal intrauterine environment. They do not cause abortion. Progestin is continuously released from the LNG-IUS devices, Mirena, Skyla, and Liletta, which also thickens cervical mucus and prevents transport of sperm into the endometrial cavity and fallopian tubes. Only a small amount of progestin is absorbed systemically, leading to lower blood levels than those in users of other progestin-containing contraceptives. The copper-covered Paragard produces a spermicidal intrauterine environment by the release of copper ions into the uterus. This makes the uterus inhospitable to sperm transport and viability. Side effects. Side effects include cramping and irregular bleeding after insertion. Menorrhagia, increased bleeding during menstruation, and dysmenorrhea, painful menstruation, are common side effects of the copper-containing Paragard. Irregular bleeding or spotting may occur with an IUD in the early months, but is less common with the LNG-IUS and may be followed by amenorrhea. The LNG-IUS may be used in women who had menorrhagia before using an IUD as a non-surgical way to manage heavy menstrual bleeding. Ibuprofen or other non-steroidal anti-inflammatory drugs may reduce bleeding and cramping. Some women will require iron supplementation to treat anemia that is related to Paragard. Complications include perforation of the uterus at the time of insertion, as well as expulsion, which occurs in 1 to 5% of users. Although the rate of ectopic pregnancies in IUD users is much less than that in women not using contraceptives, pregnancies that do occur are more likely to be ectopic or result in spontaneous abortion or preterm birth. Women with recent or recurrent pelvic infections, a history of ectopic pregnancy, bleeding disorders, or abnormalities of the uterus should choose another contraceptive method. There is a small risk for infection from contamination at the time of insertion, and this can be mediated by strict sterile technique during insertion. The IUD should not be inserted if a woman has macropurulent cervical discharge, that is suspicious for STD, or current infections such as chlamydia, gonorrhea, or pelvic inflammatory disease. Teaching the woman about side effects and what to expect in terms of potential change in bleeding patterns is very important. It is also a good idea for a woman to check for the presence of the plastic threads or strings extending from the IUD into the vagina. Expulsion, though uncommon, may occur during menses. Therefore, the woman should feel for the threads weekly for the first 4 weeks, then monthly after menses, and if she has signs of expulsion, cramping, or unexpected bleeding. If the threads are longer or shorter than they were previously, she should see her healthcare provider. Signs and symptoms of infection such as unusual vaginal pain, foul-smelling discharge, pelvic pain, or fever should prompt a call to the healthcare provider. Any signs of pregnancy should be reported to rule out ectopic pregnancy or spontaneous abortion. The IUD should be removed promptly if pregnancy is confirmed.